Okay. Please introduce yourself. Start. Good morning. My name is Mr. Mishri. I'm a fellow at hospital. Today I'm going to the ECG conference. For today's ECG conference, I have chosen one ECG which I saw back in my town in 2 years back in 2024. So this is the this is the ECG, and can we have your comments? So who will start first?
Dr. Zhang, it is good news. We have good news. Dr. Zhang for the caliper.
Yes.
First over, heart rate is about 120, and I can find T wave, and the axis is left axis deviation, and based on the QRS morphology, I think I can find two patterns of the QRS pattern.
Oh, yeah.
And I mean, based on lead V1 and V2, I can find kind of deep S wave. So I can see the pattern of the repolarization is light. So I think there is a problem of left side conduction, I guess.
Why? Why left side?
Because I mean,
problem.
Because of, I mean, the negative deep S wave
And which lead?
on V1 and V2. No.
Okay, take your time.
Yeah.
And we will rotate. They'll come back to you again. Okay?
Okay. As I can see, the sinus rhythm, I'm happy with about the 130 beats per minute, and of course the left axis deviation. And also I can see the P hydraulis and lead 2 and V4. That could be the patient have left atrial enlargement. And also I can see the Benjamini atrial perimetral complex. But Benjamin EPC and also the normal sinus rhythm and the EPC's how can I say left alternance different can see the different alternance.
Which one do you think is APC?
The sinus rhythm, then after
which lead? Always tell us the lead.
all.
Can you follow your mouse? What?
All the after every sinus beat next.
Which lead?
Lead
first.
Lead 1.
We need to be synchronized with your brain.
Lead 1.
Lead 1. Okay.
The next one. The second one is the sinus beat. Mm-hmm. The next one is looks like a atrial perimetral complex.
Why do you believe it is the APC?
Because the this beat occurred earlier, and the QRS complex is quite similar, quite narrow.
Similar, but I don't think it's the same. Right? It's group beating.
Cool.
Right? It's different.
Yes, quite
now
different.
Look at V1. So first QRS, second QRS, they are apparently different.
Now I
Okay,
can see.
take your time. We'll come back after rotation. Okay, Dr. Nam, new bridegroom. We have a rule. If there's 5 seconds silence, we will move to next people. Okay, it's okay to move to topic.
So there's a P wave, and then followed by two QRSs, which have slightly different morphologies. The QRS is in pairs before each. So we have a P wave, a pair of QRS, another P wave, a pair of QRS. That's how it is. And the QRSs, the morphology is slightly different. The amplitude is also slightly different. The second QRS in the pair does not have a P wave preceding it, and it doesn't seem to have a retrograde P wave either. So I'm thinking of two things. One is that it can be sinus with bigeminy of junctional ectopic beats because there's no P wave and it's narrow even though it looks different. The other is that possibly this patient has dual AV node physiology, and so the same sinus beat is going down, so that the first QRS probably goes down the fast pathway, and the second one down the slow pathway. So one P wave conducting down both.
You are meaning the 1 to 2 conduction.
Yes.
Single P wave conduct to first one through fast,
Second
second
one
one
through slow.
slow.
And I think when you look at the first QRS after the sinus beat, after the P wave, that one is broader. And then the second one is narrower than the first. I don't know if maybe it can be an example of gap phenomenon where the slower conduction improves so the first one, because it's broader, maybe there's some degree of conduction system block. But then
if it is gap phenomenon, second QRS should be conduction delay or conduction block. Don't you think so?
with the gap phenomenon, the first slower proximal conduction allows for recovery distally.
Yes.
So you will have a narrower.
Oh, that's why. Okay, so
That's
because it gives you the conduction system recovery time.
Yes, so maybe that's why the second one is a little narrower than the first one.
But I'm not sure depending on the refractive period. Okay, that's good hypothesis. Good try. So you propose two different diagnoses.
Yeah.
Okay. That one, please.
Yeah. As our colleagues already mentioned, I think the sinus rhythm with the junctional rhythm, like the group beat, I think that is the most possible. Maybe AV node or one to two conduction may be possible, but I'm not sure. But I don't almost same as okay.
1 to 2 conduction?
Maybe, but more likely with junctional rhythm,
Junctional bigeminy?
I think.
Junctional bigeminy.
Yeah.
Okay. Dr. Park?
My thoughts. I think it is APC function because if you see in wave one, the if you see in the T wave, it's
Which lead? Oh. Yeah, tell us.
in what the
One.
the obvious one with the P wave should be the sinus rhythm.
Mhm.
And the T wave is different from the APC T wave,
Mhm.
which might a premature beat might be used with the T wave, and because of because this patient has an intraventricular conduction with a conduction system disease, right?
Why do you think? I think it's apparent now for us.
Yeah, it's narrow curves, but slightly wider if you see one.
Can you measure I cannot see the grid. It's longer than 120 milliseconds.
Current question might have like slightly short.
Yeah, the first and second course with this different.
Hypothesis 20 milliseconds.
Hmm?
So that
Oh.
Okay, California.
Similar, right? Okay. So thank you very much for your suggestions. Number one, HR by Gemini, as Yundari and Dr. Park suggested, and the wanted conduction by Coffee and Dr. Huang. And the third one would be the block, no, the junction by Gemini. I'm not sure the gap phenomenon is acceptable for this because there's no block, right? So, okay, so we rotate the ones. Anything else to add?
No, I agree with
APC.
Yeah.
Okay.
Thank
Yundari,
you. Mm.
still APC by Gemini. Okay. Dr. Nam?
In my opinion, there's a slightly different curse height between the first and second block. I mean, first and third will be the same, and second and fourth will be the same. So I'm not sure, but there will be different curse height.
Okay, not sure. I'm not sure that Dr. Huang, Dr. Huang number one, original Dr. Huang is here.
Okay. Can you guys hear me?
I'm sorry. I'm sorry. I thought that you're in the aircraft.
Okay. Can you guys hear me?
Yes,
Yes.
here.
Okay. So puzzle of this question is you have a bigeminal pattern going on. First visible P wave is quite abnormal. It's wide and tall. So you have to assume this patient has probably some atrial disease, maybe by atrial enlargement. But if you look at the coupling of a bigemini, they vary. They're not same. Look at the, for example, precordial lead. Let's look at it. B4, B5, if you look at maybe more obvious for you to see, first two beat compared to the second two beat, coupling different, not same. So you need to explain that first. If this is a junctional rhythm, I assume this isorhythmic junctional rhythm, you expect to see premature beat coupling should be same, but it doesn't. It's varied. Secondly, premature appearing complex is narrowish looking. Then you conducted the P wave QRS complex. So that favor for what? It's not a just junctional rhythm. Has to be lower conduction system maybe? That baseline sinus has what? Anterior fascicular block? You agree? Look at the QRS axis of a conducted P wave. It's a northeast axis, isn't it? Lead 1, AVF is a tau positive. 2, 3, AVF is a negative S wave. So it's a patient of a sinus rhythm with the left anterior fascicular block. I think that's the baseline rhythm of this patient with some significant atrial disease. And then now I have a second complex follow, coupling very little bit, and also between the RR interval fascicular rhythm also change. Therefore, this favor for what? Some sort of automaticity going on here. So the other differential diagnosis would be what happens if you have a conduction system PVC intercoupling with the anterior fascicular rhythm. That would be other diagnosis. You have to put it in here. Even though you guys put a variety of good diagnosis, good thinking, that may explain why the QRS is narrower, axes are slightly different, and then coupling is different. Okay? So that's all I can add on your differential diagnosis. Question is, does this narrow complex has a VA conduction or not? That would be the question. Do you think a second premature complex has a VA conduction if this is a ventricular rhythm? What do you think? Every complex followed by that, whatever that narrow complex T wave is deformed if you compare to the sinus rhythm T wave. Do you think that potentially might be another retrograde atrial activity going on there? Especially if you look at some noisy in there, I agree, but then precordially, it certainly doesn't look normal. Terminal T wave, V3, for example, you got a T and then long, prolonged notching, much longer, wider than sinus P waves. So you wonder whether there's any retrograde activity going on from the VA conduction standpoint view. Okay? So that's something that needed to consider here. So additional diagnosis would be maybe fascicular bigeminy going on, sinus rhythm with the fascicular bigeminy. That's the differential diagnosis. You have to put it in here. Okay?
Dr. Yu is sitting under Dr. Wang's chair.
Oh, good.
No.
Sit down.
I'm happy to hear that someone took over my job. That's good.
Yeah. I already believe that the simple explanation is the best. So my differential diagnosis number one is APC by Gemini, because I want to ask to Dr. Huang, not the original Huang, the imitation Huang. If that were the junctional by Gemini, as you said, as you proposed, then how can you explain the different distinct T-wave morphology between the two bits? Especially you can see the clearly different T-wave height and morphology in V1, 2, 3, and 4 as well. So how can you explain? And that copy, yeah, the hypothesis of 1 to 2 is very interesting. Yeah, but I know that is very rare phenomenon, and if the second, the premature QRS complex are coming from the P wave, then can you measure the PR interval?
The second one.
P wave from the second QRS and to the You can be able to click for the
Okay.
Yeah.
Yeah. wider than the market.
That is meaningless. Yeah. Just count the scale. It's more than 600 milliseconds, right?
Yeah.
Yeah.
It's around 500.
Five or 600 milliseconds.
200, 400,
So
maybe
actually,
580.
currently the copy is measuring the multiple intervals by utilizing the Dr. Zhang's calculator.
It's about 560.
Yeah.
560.
Yeah. So, because my humble and limited experience, I want to ask to Dr. not Park. Yeah. Have you ever seen the A.H. Jones measuring the PR interval like 500 or 600
Yeah, I saw.
milliseconds? Really? Yeah, I have not. So, yeah. So that,
My answer is simple. I saw.
okay, yeah. But I haven't seen yet. Yeah.
So first of all, I appreciate the watching to bring up the very interesting ECG, and moreover, I'm very happy to the fellows suggest so many different differential diagnosis is the brain exercise. So I don't think that we cannot make a conclusive diagnosis by a single ECG, one sheet of ECG, but we need to try to find out the mechanism. As Dr. Huang mentioned, that there is some irregularity, but it is not apparent. But if you look at the V2, T-wave morphology is quite apparently different, right? First and second here. If it is the junctional rhythm, QRS morphology a little different to the sinus node, the atrial conducted QRS, but usually the QRS, the T-wave morphology could be similar, but this is quite different. So there's two possibilities. Number one, there is a hidden APC wave or retorted P wave from the first QRS is overlapped. But I cannot see we can see the P wave, retorted P wave morphology in the lead 2-3 ABF, we can define it, but hard to say. But still, I cannot exclude the diagnosis of a 1-2 conduction utilizing the dual avenue physiology. It is just because very interesting to know.
Dr. Park,
Yes.
if you look at the leader 2,
Yeah.
I want you to look at the third beat just before that. There's a small, tiny spike on T.
Can you follow the mouse?
Yeah, that guy. And then look at the last bit, only show that same morphology. Very last, leader 2.
Wow.
Next one.
Wow.
That one, next one too. No, go to the next one. Last one. There you go. Now, what do you say? Do you still think this is a 1P, 2B?
Oh my God.
Idea of 1 to 2B is out of window here, okay? Secondly, Dr. Yu said 1 to 2 window that long? I don't think so. So I think we have to explain why the QRS morphology change and becoming narrow, and all this need to be explained. And I think this patient first complex T wave is normal, PA premature beat, whatever, probably has a red with the atrial conduction, with the biting coupling intervals, the influencing subsequent RR interval. I think this is probably some sort of ventricular origin rhythm has to be. Junctional also doesn't explain why the QR is changing either. So all this still need to be put in priority, and then you can think a differential diagnosis. Okay? For fellows, that's important, exercise.
Wow, you saw that. It's amazing. Okay, so because we will have international conference from 9 o'clock, please open the answer.
So this was a little bit medical background. I know which we saw in 2024. She had recurrent palpitations for 3 years that time, and echo was showing borderline ejection fraction of 50% and mildly enlarged LV cavity. She was being treated for frequent APCs with beta blockers, but she was having lately more frequent and more persistent palpitations, and now had begun to experience NYHA class 2 breathlessness on exertion. So the differential diagnosis, as has been discussed here, includes atrial bigeminy. But one point against atrial bigeminy is the absence of a clearly abnormal P wave before the ectopic beat. We are not able to identify a clearly abnormal P wave. APC should begin with a slightly different morphology P wave. Another is junctional bigeminy with a retrograde conduction block, because we cannot pinpoint a retrograde P wave here. So that is another possibility. Third is AVNRT with the reentrant circuit using two distinct beat-to-beat alternately slow AV nodal pathways integratedly and a single fast pathway retrogradely. And third is a AVRT with alternating, very rare AVRT with alternating AV conduction over a slow and a fast nodal pathway, as well as a VA conduction over an existing pathway. Very, very rare. But we did the EP study of this patient, and it was actually a 1:2 double fire tachycardia with one sinus beat and two ventricular responses. So, and the PR interval was in the 500 range. I don't remember exact, but it was a very slow pathway was 530 or something around that. And the fast pathway was short. And so the diagnosis was dual AV nodal, non-reentrant nodal tachycardia. It's also called double fire tachycardia. The surface ECG characterizes a sinus P wave followed by two narrow QRS complexes. The sinus P wave could be superimposed on the preceding complex. Here, it was quite visible, but it could be, but it can have varied presentations. It can fall on P wave, ST segment, making the DAV, this diagnosis very difficult. Hence, it is also often misdiagnosed as premature atrial or ventricular complexes, supraventricular tachycardia, atrial fibrillation, or even sometimes VT. This can lead to tachycardiomyopathy, because suppose if the sinus rate is 100, the ventricular rate is effectively 200. So this can, and this patient was about her LV cavity was dilating, and this treatment is slow pathway ablation. This is a post slow pathway ablation, and the patient was then free of palpitations, and her ejection fraction improved over the next 3-4 months. Thank you.
So I got a question for you. Quick question. How do you explain the QRS alteration and the narrow itch complex?
There is a nice review in Europace 2016 about DAVNRT, and there can be different QRS morphologies in the two beats, and I didn't understand the explanation yet, but I can forward the article to everybody.
Let's take a look at that article, because of if you have, unless this unusual, what I call anterior superior AV node, I assume you ablated regular slow pathway, correct?
Regular slow pathway.
Yes. So that would not explain your tracing, why the QRS alternating, especially become narrowish. That's another thing that worries me. Okay. So where the PAC coming from? You said the frequent PAC, so you guys saw in the monitor.
No, it was treated on ECG as PAC, but I mean, it was previously being treated with beta blockers as atrial bigeminy, but she was not responding.
Okay.
If it is possible, let's share the electro.
Yesterday, I had asked my lab tech to find out, then maybe I can.
Okay. Thank you very much.
Thank you so much.
Okay, you deserve one more cup of coffee.
Okay. Actually, Professor Dae-hoon Kim is a moderator, but due to the he have another lectures, and so Instead of him, I will become moderator of today's International EGM case conference, and I'm very glad to introduce our today's presenters from Cambodia, Dr. Sok Sok Khan. Are you there? Oh,
Hi, Dr. Sokhan. Good morning.
hello, Dr. Sok Khan.
Morning,
We
everyone.
can't hear you. No, I can hear you. Hello.
Hello, you can hear me now?
Yeah, now we can hear you.
Thank you. Hello, Professor Park. Hello, Dr. Chun. And hello, all doctor from Malaysia, Mongolia, and our colleague from Cambodia. My name is Sokhan, EP doctor from Cambodia. And today I have one topic to be present. Can I start right now?
Yeah, you can start, but before starting, I will briefly introduce our today's panel, the Dr. Xiu Yun Ki from Malaysia.
Hello, Dr. Key.
Morning, everybody.
Good morning.
Hello.
Now, Dr. Sokhan, you can start today's presentation.
Got it. So I have one case that we did with Dr. Chun Hong, maybe 1 year and a half for the young lady. The 26 years old female patient come for pre-syncope and paroxysmal palpitation. No any history. We did EKG. We have a sinus rim with a lot of PVC from the left side. And we did the heart ultrasound. We saw the moderate mitral insufficiency with by left mitral valve collapse with the normal LV ejection fraction and with the normal thyroid function. It is the heart ultrasound. We see the bileaflet mitral valve collapse. Yes, it's not only one valve collapse, but bileaflet. And we have the Pickett Hall sign. It's mitral valve. Yeah. And we had the posterior, she had the posterior annular disjunction 10 millimeter. So it's too long. Yeah. With the or grade 2, yeah. With mid telesystolic, yeah. Yes. So we think it is moderate or, yeah. With the bileaflet mitral collapse. But when we did the heart ultrasound, she had a lot of PVC, but by Gemini, so we cannot estimate is moderate or severe or we don't know. Yeah. And we did the transesophageal heart ultrasound also. Yeah. Sorry. It doesn't work. Sorry. The video doesn't work. So it's for her EKG with the sinarium, but with a lot of PVC by Gemini, the PVC from the left side, the positive in V1 and negative in inferior lid. So we think from the inferior of the LV, yeah. And we find the location of the PVC come from papilla muscle, from the posterior subtopalpal muscle. Yeah. The same morphology in EKG. Clearly, yeah. So we did a 24-hour further EKG. The patient have a sinus bradycardy with a long shooting, yeah, maybe around 400 milliseconds. And we saw a lot of PVC with non-sustainability like this. So okay, so with the young patient with a lot of PVC come from the posterior muscle with the bileaflet mitral prolapse with analog distension around 10 millimeters. So we see this patient have the high risk of a sudden cardiac death of the mitral valve prolapse syndrome. So the question is, we need to put an ICD to primary prevention, or we need to do ablation first. So it's the question that we need to answer before to do the management for this patient. So in this case, I discussed with Dr. Chun Hong. So we try to do ablation first and let wait and see. So we explain the patient to do ablation, but unfortunately, we don't have a 3D map technician at that time. So we did a video fluoroscopy with this challenging case. So I will show you back here. So in the EP lab, in baseline EKG, we have log PVC from the left side, but I saw we have one lead is a bit different from another lead. Yeah, it's lead 3. I think it's PVC1, a bit negative, and PVC2 a bit positive and negative isolated. Another PVC in lead 3, maybe PVC3, who from the same location but different axis. So maybe she have a lot of PVC from the papilla muscle. We don't know yet. So we try to do mapping. So Dr. Chun Hong told us to do LV angiogram to see what happened with the LV because we don't have a cardiac MRI in our center. So we did the LV ventilography with contrast injection. So we see this point is the location of the mitral prolapse. It's really prolapse, but I cannot add the video in this in my slide. And we put the LV catheter to map around the papilla muscle, and it shows us that the most early of signal around the LV12 and 34. So we saw the small potential, fragment potential in LV34. So it's photoreceptor part muscle. Yes. And we did the test mapping at LV34. So we got the most, maybe the same morphology is the clinical PVC. So we think it's the best point, the best location to do update here at LV34. Yeah. So at that time, to do the risk stratification, we did the program ventricular stimulation with 1 extra stimulus, and then 2, and then 3, at apical RV, and then RV to induce sustained VT. But at that time, we cannot induce any sustained VT or VF. We cannot. The patient don't have a beta blocker, don't have a flecainide. We stop it more than 5 days before the ablation. but we cannot induce any VT. The question is, the patient is still the high risk for sudden cardiac death in mitral prolapse syndrome or not? So we cannot answer it yet. But unfortunately, at that time, when we test the V pacing, yeah, so we have another tachycardy, narrow shield tachycardy with cycle length around 384 milliseconds with a short VO, yes, and it's a type called AVNOT, it's confirmed. So this patient, she has two problems. He has an SVT from the pulmonary muscle and slow pathway AVNOT, type 4 AVNOT. Yes, this patient, he has two. So we try to burn the PVC from the pulmonary muscle and then ablate the slow pathway. So we have two points to do here. So we did the transeptal puncture to get our irrigated ablation through the SL1, and we try to map again at LV34, and we got the signal fragmental in ablation distal. The most earlier signal at LV34, okay, minus 39 millisecond, and early then LV34 minus 10 millisecond. So we think it's the best point. It's a good point to do ablate. So we ablate there, yeah. You ablate here, LV34, yeah. But unfortunately, we cannot completely eliminate the PVC. So we try to map again around the pulp muscle, move the catheter, pull back, advance, a lot of time, but we cannot eliminate completely the PVC. And I think we feel our catheter is a bit unstable, maybe because of mitral valve prolapse. So our catheter a bit unstable. So we try to map again and again, and we got another signal fragmental, but we think it's artifact or another fragmental signal. We don't know, but it's early than LV34. So we try to burn here, but we cannot eliminate completely the PVC again. So we change the strategy. So we stop to burn PVC around the pulmonary muscle because we burn a lot of application. So we did only to do ablation the slow pathway. So we ablate from the left side, slow pathway. So we got it and we burn, and we got the junctional rim during OF. And after we did the atrial pacing, yes. And we press again and again. We don't have any A jump yet. So after the result, we have a complete ablation of a slow pathway AVNOT, but we cannot completely ablation of PVC from posterior pulmonary muscle of LV. Yes. And then the patient discharged and came to see me 1 month later. She still have the same symptom, pre-syncope and palpitation, and I did the 24-hour alter EKG. The burden of the PVC and more than 10%. So we discuss with the Chun Hong and with the Jeremiah Hope team, American team. So we explain patient again to do ablation with the 3D map. And this time we have a 3D map technician. So we did with 3D mapping system. Yeah. But we change a bit the strategy. before we did with through the transeptal transeptal approach, and we think our catheter a bit unstable because of a mitral valve collapse. So we changed the strategy. We did it with the retrograde of, at this time, our catheter a bit stable than before, but I don't know which one is the best approach to do ablation from at the pulmonary muscle. In this case, with the bileaflet mitral collapse, but retroval optic, I can feel it's more stable than transeptal approach. So this time we did with the grid catheter to map in LV and to map around the pulmonary muscle, more apical and more subtle, to get the best signal, the good point to do ablation. So we can see the white spot one is the best, the most earlier signal here, and more apical than subtle at the pulmonary muscle. So it's too apical, yeah. So we try to map around here and burn at the white point, this point here. So we try to burn at the white spot and around the white spot multiple times to get completely, to eliminate completely the PVC as we can. So we burn a lot of application here, the white spot and around the white spot. And the most earlier signal is the white spot like this, score 97%, and earliest minus 61 millisecond. And we got the good result. After ablation, she don't have any PVC, and the patient discharged 1 day after and came back to see me. I repeat the 24-hour alter EKG. She still have the PVC, but the
Not
Oh, problem. Maybe his network is frozen. Yeah, problem. I think it's his network because we can't see the other person.
Oh,
Dr. Wong,
And-
can you proceed the discussion? Oh, he
he's
came
back.
back. He came back.
Yeah, I think my internet network is
sorry,
not
sorry,
very
my
good.
internet cut off. Okay, so my slide presentation is finished here. So we did 2 ablation at the same patient 2 times. So you have any comment or anything else? Yeah.
Thank you so much, Dr. Sokan, for the great case. Should I comment or should I wait for a while? Can I go ahead?
Yeah,
All right.
Dr. You can go.
Okay. All right. Thank you so much, Dr. Huang. All right. Generally, I think this is a great case to to illustrate in a very young patients with the Holter with the salvos, which are the burst of PVCs that we definitely have to do something. And I think the medicine wise is a bit tough because the patient already started with a sinus bradycardia. So I think the beta blocker doesn't really helpful in this case, and relatively very tough. There's no choice for us for medical therapy. And I will definitely very amazed with, I mean, from the initial approach with 2D based ablation before venturing into 3D, this is really good. So very based on the electrograms. So I just have two questions that before I would like to comment on the case. The first question is that Dr. Sokan, you actually mentioned about there's no cardiac MRI was done. Is there any? Do you suspect is there any family history or any genetic studies that you think is something is running in the family, or this is just a sporadic case? This is my first question. Yeah.
Yes. She has no any medical history, so we cannot find any history of a sudden cardiac death at a young age in her family. Yeah.
All right. So it might be just you think the bilateral mitral leaflet prolapse is because of perhaps is a rheumatic fever, or I mean rheumatic heart disease?
I think the PVC from the pulmonary muscle and
Yeah.
the heart ultrasound show us is really prolapse with
Right.
the long disjunction.
All right.
10 millimeters, so it's too long. Yeah.
Okay. Is there okay? I'm just wondering whether is there any connections between the PVC and the mitral valve prolapse. The second case, I mean, the second questions that I would like to ask is, what will be your factors to decide in the beginning why you choose transeptal approach instead of retrograde transaortic approach during your first ablation?
Yes. I asked Dr. Chen Hong also, and they told me that it's the same with the retrograde approach and transeptal. So we did the transeptal first, and we hope we got the result. But unfortunately, we cannot eliminate completely. Yeah.
All right. Okay. So for my point of view, I think it's a really great case that to start with 2D, then later on venture into 3D. I think the 3D mapping is definitely helpful, and also with the contact force ablation. Of course, if there is a possibility to get a intracardiac echocardiography, even better. Yeah, to to really stabilize and to visualize where are we during the ablation will be more control, I think. Yeah, that's my comment on the case. I'm not sure whether Dr. Chun Huang or Dr. Huang have any comments on this case. Yeah.
Yeah, Dr. Sokan, thank you again for sharing this very interesting case. And I think because I am also the junior of the junior EFI step, and I don't have any experience of the VT with the 2D only. So the first question is the 3D mapping at the first sessions, was this mainly because of the institutional policy or reimbursement issues, or was there another reasons to not to use the 3D systems? And also, as the Dr. Key mentioned, ICE, if ICE was available, it is very useful to see the stability of the catheter and of the visualization of the papillary muscle. So do you usually uses ICE for not for this case, but another cases for VT? And lastly, after the ablation, do you perform any inducibility tests like the infusion of the isoproteol and also the Holter results after the procedure?
Yes, I have a question. It is also. So we try to press to do program ventricular stimulation, but we cannot got induced VT. The question is, so we did the stimulation with isoprenolol or not? Is also my question. So maybe we got false positive, or we got VT but with false positive. I don't know. So I have been questioned this also. So we did with isoprene IV or not in this case to induce VT to do risk stratification. Yeah. And our center, we don't have eye. Yeah. Unfortunately.
Okay, thank you. Are there any questions from audience?
Okay, can I ask a question?
Yeah, 2000
So after the second ablation, have you repeated the echo?
Yeah, we did it.
And there's a mitral prolapse or not?
It's the same. The
Same.
same.
Okay.
Yeah. Moderate
So
mild.
this patient meet the criteria for the mitral valve annular disjunction. Obviously, concern would be what is the risk of a sudden death this patient? Is still the same, or you think that you improve it because you eliminate PVC? What do you think?
I cannot answer the question because we cannot induce NAVT in this time. So we don't know.
Unfortunately, most of the data show that for MAD patient, mitral annular disjunction patient, some of them patient even had a surgical correction of mitral valve. They continue to have a risk of sudden death. Okay, so that means you need to follow this patient very carefully. Second point is because of lack of MRI, okay, you did a 3D mapping. If there was any voltage abnormality in your LV map, when you did a 3D mapping case, Sokan, you would create a map there. Have
Yeah.
you looked at any scar tissue, substrate? Because you have a echocardiac criteria, CT criteria, so I mean echo criteria, and then also the Doppler sign suggests consistent with the patient history. This patient is a stiff risk of sudden death. Okay, young female, mitral valve prolapse, annular disjunction, and then you got piccolo sign in echo, and then you got disjunction approximately 10 millimeter. That's way too big. Cutoff is about 5 millimeter for risk of sudden death. Most of investigators agree. So therefore, PVC elimination may improve symptomatic functionality of the patient. But I'm not sure that any data suggests that ablating this patient only without any additional protective indication, ICD and so on, whether you have still safe clinical status. That need to be answered still. There was only a handful of patient case series. Last one was published by the investigator from Australia, Queensland University. He wrote a review article and then 10 series cases, and that's still not conclusive. So I would be concerned. As you said, this is patient 12 ECG. What do you see? Can you take a look at a 12 ECG? Show me sinus rhythm ECG. You showed to us. No sinus. Yeah, this is, yeah, there you go. What do you see here? What do you think is the most profound finding here? U wave, gigantic U wave. Do you see leader 2? Second hump? Okay. And you mentioned something about the long QT. This is not a long QT. This is gigantic U wave.
Yeah, you will.
So you need to correct that QT measurement. Okay? Which you can see in before, leader 2, leader 3, so on. So you need to be careful when you read this ECG. Okay?
Okay, fine.
Okay. Let's go to the case now. We did the first approach of a biventricular approach, what we call. Oh, just go back to EKG. Just let me make a comment. Quickly, tracing. Yeah, there we go. You talked about PVC 1 to 3. This is basically difference in exit site of the same PVC having wide range of lead 3 changes because the inferior axis is more sensitive. But if you look at the PVC1 and PVC2, you merge it together, become PVC3. Okay?
Okay.
So this is basically varying degree of axis variation, probably single area causing this. But this means what? So possible explanation for this would be one, whether this involve different exit conduction system around that focus that you're addressing. Second, could it be a little bit deeper than usual focus, which can cause a precursor conduction variation. Okay? So now, is this EKG morphology? It consists of the typical papillary muscle, you think? Or not?
Yeah.
That's another question. You think?
Yes. Yeah, I think from the pulp muscle. Yeah.
You sure?
I'm
Go
not
back
sure
to
for
your
the person.
go back to your diagram. You show nice diagram differential work done by the other investigator. Okay, right here. So it's a posterior papillary muscle. B1. Single hump or double hump?
Double hump.
Your EKG. Single hump or double hump?
Lead one or V1, Dr. Chinong?
B1.
V1, double hump.
Your 12 lead ECG, I'm talking, not this classification. Go back to your 12 lead ECG. B1. Single hump or double hump?
Single hump, yeah.
Single hump. All the way through the precordium. V3, V4, all the way to the V5. Why is that? If you go back to your classification again, go take a look. What do you say? No, you just share the classification right there. You showed me the slide before. Yeah, that one. Look at the posterior papillary V through the V6. What do you say? Single hump or double hump? Mostly double hump. Okay.
Double. Yeah.
Because this is not an exact papillary muscle PVC you're bleeding. It's around the papillary muscle, is not a papillary muscle PVC. I don't think so. Okay.
Yeah.
Let's go to the next. Go down the case. The reason with the double approach is that when you dealing with such a variable conduction and different axis manifesting QRS complexes, you're not sure where this is coming from. I like to have a second mapping catheter in the left ventricle, especially when you have a no 3D. So you have a good idea where you're heading. So if you're mapping with a two catheter, which is faster than mapping just one with ablation, even though you have a good angiogram, you can see nicely posterior papillary muscle aerial angio 30-degree angle. Sokan pointed out earlier. But you don't know actually where your catheter is in the subtle side, the posterior side, the free wall side when you put the catheter in. So having two catheter give you better reference how to move a catheter, especially in the setting of a no 3D. 3D in many third world countries are luxury, like especially where we work. Cambodia, Myanmar, Mongolia, they may have 3D, but many times lack of technical support. They cannot have all the time 3D mapper with you. Also, nursing staffs, many assistant staffs, they're not trained to do 3D mapping. Okay? So this is a limitation that you're going to face most of these countries. So that's one of the reasons that the 3D is not available, lack of support, lack of training. That's why KCR is trying to address that issue. Okay, next go. So if you look at the catheter placement right now, you think that your transaortic catheter is in the good spot? At least you know it's not in posterior fascicle. That's all you can say. There's no fascicular potential here. Typically, if you have a fascicular VT, you like to have a nice fascicular, potential. We put the catheter, mapping catheter, we could find the earliest site, and we park there and left it there as a reference. Okay? I agree with you, catheter is not stable because transaortic. But if you look at the PVC first complex, second complex, the EGM slightly changed. And then also second complex, very sharp distinctive potential in the LV1, I think 5 and 6, which is earliest. Okay? The first bit is far field early, but we cannot tell how early that it is. You draw the line there. Okay, next bit. Next go, next slide. You get the second bit, there's a small sharp potential in the front, okay? Okay, here, you find a spot, you pace map. you said the pacemaker is good. Your overall axis looks the same, but the QRS is much wider than clinical PVC, right? So that can distort your pace mapping. That may be because we haven't paying attention to the output of pacing. Capturing large area can often mislead. So you should be pacing lowest output, first bit of capture, then you should compare that. But you're in ballpark region. You're not in the, really perfect place, what we call. So this is just confirmation that the way you think that this focus might be, but not to guide the ablation in a sense. Okay, next. And basically you did the EP study, not inducibility. What does that mean, not inducibility? Is that predict anything in terms of MAD disease? There's any clinical data showing that positive EP study versus negative EP study predict any outcome, this patient? As far as I know, no such data. Okay? So we cannot rely solely on EP study saying that the patient is safe, not safe, or prognostically better or worse. So there's no consensus on this. Okay? Next. And that's ABNRT. Okay, keep going. Okay, keep going. Because when we did this study, we were a little bit, concerned because the patient had the ABNRT and patient had a pre-syncopal history. Remember your history? So the question is that ABNRT causing pre-syncope or VT causing pre-syncope. And the ABNRT is equally symptomatic, some young patients. So the question was that we wasn't sure. We presumed that possibly ABNRT is causing more symptoms. So we had a successful ablation. And then as you point out, this ablation signal, if you look at the first complex, okay? That's, you think this is a clinical PVC?
Yeah, yeah.
I don't think so. It's too wide. Okay? So got to make sure that when you see that, it is not a cata-induced. And then second complex. That's your second complex you see in the tracing. Axes are completely different, right?
Right.
But you have a very small fragmented far field, like a Purkinje, like a potential. Obviously wrong. EGM, okay? And then one comment I have about this ablation PVC that you draw the line, initial is Q, not R. Second, proximal is earlier than distal. Okay, let's go next. Yeah, and this is a better signal to ablate because you got much earlier, not just because of fragmented, but the initial component is the R, begin with the R wave, small R wave, but it's very far field. Possibly it could be a deep tissue or could it be a, some scar tissue? It's hard to know. But the local EGM also very low amplitude. So I'm assuming that this is probably scar based on the EGM. That's why I asked you earlier whether you had any scar tissue in your 3D mapping when you perform the second procedure. So if you go back to your second map, second procedure with the Jeremiah Hope, let's look at the voltage map, all that. Take a look. Okay, this map was created by the grid catheter, right?
Right.
I have two questions for you. Right there, that map, first map, go back. Yeah, in this map, you have two white spots. Do you agree? One is the lateral, the other one is where you put the red arrow or red star. Which one is the earlier?
Is
That
white
one?
spot. Yeah, that one.
And then the front one is what? You think is the artifact? There's another white spot at the right at the, top of the lateral wall. Another white color on the map. You see that, you see in this map too. On the left side of the map, there's another white spot in the front. There's a two white spots. Can you see it? On the left map, there's a front aspect, a lateral wall. You're taking posterior septum there, anterior septum. Move arrow to the anterior septum, there is another white color there. You're not understanding what I'm saying, right?
Yeah.
You know, about across the lateral wall to the lateral, there's a small spot. So question I have is that whether the mapping, here also you have a two white spot, tiny one and big one and small one. Do you see it?
Yeah. Yeah.
The point arrow so everybody can share this because it's important. That one and just small tiny spot right above it. Supposed to go up to the little bit higher, come higher, not that one, keep coming. Yeah, that guy. He's also present in your other map. When you see two spot, early spot in your map, what does that mean? 3D. How we can say that the two early spot is present in 3D map? That usually, if a re-entry, your map is wrong. But we believe it's a focal tachycardia. That means endocardial two breakthrough spot early mean deep focus PVC. That's what that means. Okay? It's important to you examine your map after the ablation. Think about why you see two early spot. So you choose to ablate the bigger area, bottom one. You left that tiny white guy up there. So I don't know whether if you had the ablation of that small guy up there first, you may not have to put so many burns, maybe. That question still remains, okay? So you should check the both sides first before you ablate. And or correct your map. Maybe that's the wrong spot as well. Maybe they tagged the wrong area. But if your map is correct, then you're talking about deep tissue, two break side through, okay? There's a nice paper written by Circa Arrhythmia, Basic Science Group in 2022. There's a good paper to review this aspect of a 3D mapping. Okay. Keep going. So you ablate a pretty wide area, but you don't know where did you ablate. Doesn't line looks like you ablate a papillary muscle because your papillary muscle looks like above the where your ablation site was, seems to me. Because of that depression that you see above the red spot, I think that's a papillary muscle. I'm guessing right now. So that's why you have that tip indentation in the endocardial map. Okay? So this would not be something that I expect to see in patient with the MAD scar disease. MAD scar disease is usually superior to the papillary muscle, okay, not below. So perhaps this patient had a mitral valve annular disjunction, but the PVC focus probably below the papillary muscle. That's what I can say, okay? So after the ablation, you following her, she had normal PVC, I hope.
She still have PVC, but then less than 10% and less
So what's the percentage she has? Did you look at the Holter? How's the percentage follow Holter? What was it? Do you know?
She told me she have no pre-syncope as before.
Right, but then no, I'm asking you follow Holter. So what percentage of PVC? That's what I'm asking.
Yeah.
Is it frequent PVC still?
No, not still. Yeah.
You said the patient has a PVC. It's like a different morphology. Am I right?
1 month after the second ablation. Yeah.
Yes. So she is symptom free, no PVC, I assume. She's still having PVC, Sokan, or no?
Yes, she still have, but
Okay.
then less than 10%.
Yeah, 10%. That's an important issue because about that white spot that you had, second spot that I showed you. Okay.
Yeah.
Next time when you have such a question, you can do two things. One, you can go there, pace map, low energy output to see morphology that area and other area as well. So compare which one you want to ablate first. Okay. Maybe this patient had the same PVC with a slight different exit site change. because of deep focus, you may just create a conduction block in a more common exit site. Okay? That's why I'm asking all those questions. That's it. I have all for you. Anybody else have any question? Dr. Huang, Junior Huang, take over.
Thank you, original Huang. And and is there anybody who wants to comment or do you have
Yeah,
any questions?
this is Hinan Park from Korea. Dr. Sokhan, I enjoyed your wonderful case, and it's a very nice case. Even though you try to ablate two different arrhythmia by invasive procedures. As far as I know, the MAD, mitral annular disjunction, has a risk of sudden death. As Dr. Huang mentioned, if the disjunctional degree is more than 8 to 10 millimeter, and MRI scar or history of syncope or cardiac arrest and family history, probably we need to consider the ICD implantation. And the most common site of PVC is the area of mitral annular disjunction. So mitral annulus area or LV summit, and the opposite side stretched cauda tendinae might affect the PVC from the posterior papillary muscle. So two different PVC foci are the most vulnerable site of PVC origin. But anyway, you successfully reduced the PVC burden in this patient. Actually, when I visited your lab the last March, I observed another case of mitral annular disjunction. But however, in Korea, it is extremely rare to see the mitral annular disjunction. So I wonder, is it common in Cambodia or Malaysia? I mean, not only mitral valve prolapse, but I'm talking about the mitral annular disjunction.
From my side, I think in Malaysia, I personally actually I think I've only seen one or two cases by myself. I mean, my colleague actually commented, so not that frequent that I've seen. Yeah, that is from Malaysia.
Yeah, how about in Cambodia?
Good morning, Professor Park. Can you hear me?
Yes, we can hear you, Han.
For my experience, for the last 5 years that I practiced, I've seen only around 1 or 2 patients on the two. That based on my experience, but I don't know. Sometimes he has seen how many patients already.
I see. Still, it is not that common in Southeast Asia, but I think more common than in Korea. Anyway, I enjoy the case, and thank you very much.
So can I have a last comment for you? How you planning to follow this patient? Every 6 months, or what are you going to do?
So the patient come to see me every 3 months.
Okay.
To repeat for
reason I ask, reason I ask you is that if you look at this aft ablation ECG, your gigantic U wave is still there. You see it?
Yeah.
Yeah, V2, V3, V4, and then lead 2. So keep monitoring. Some people argue or they recommend that the presence of a gigantic U wave is still at potential considered risk of sudden death. Okay? So just keep an eye on her. Okay.
Dr. Chong, I have one question.
Yes.
To do a restart patient in this case, we do a program ventricular stimulation. So the benefits isoprenolol. So we can test with isoprenolol to induce VT. What do you think?
You know, it has been quite controversial whether use of isoprenolol would enhance the inducibility of such as patients. You have to remember papillary muscle is if this is what you think, but U waves are originated from Purkinje network, we initially thought, right? So if that's the case, isoprene may enhance inducibility to the calcium-mediated mechanism, not by the increasing the catecholamine. Okay, so that's possible. But I wonder whether we needed to pace instead of S1, S2, S3 similar sequence. Maybe we should have done long shot cycle like a long QT to see whether we can trigger the AD mechanism. But those all I don't think is in the clinical practice arena, all research arena right now, as far as I know. Okay. And people use isoprene routinely, probably yes, but I don't know what that does enhance inducibility or not. That's certainly not fully tested yet. Okay.
And I have another question, because in this case, he have two problems, PVC from the left side with the typical MVNOT. And I have also another case with the OVOT, non-sustainability, and patient have also typical MOT. So I have two cases, patient with two arrhythmia.
Yes.
So for your experience, did you see a lot, and it has association between the slow pathway with the VT or not? It's my question.
Yes, there is a high incidence of AVNRT cases among the frequent PVC patients, also in fascicular VT, particularly. And then also you can have any other frequent ventricular arrhythmia. Then we just think that the retrograde pillback constant concealment of the anterograde conduction maybe enhance the slow pathway conduction eventually because of AVNRT. If you look at the fascicular VT cases, for example, up to 18% cases been associated with AVNRT simultaneously found in the same patient. In some cases, double tachycardia also present, similarly. And IBOT is also very common. Frequent PBC patient, you do induction AVNRT. Many of them, we have inducibility AVNRT. So I think this has to do with the interaction between PBC, retrograde concealment of the nodal area, whether that modulate the slow pathway condition or not. That's proven to be, but my impression is appears to be that's what's happening. Okay?
Okay, thank you, Dr. Hong. Yeah.
Are there any more comments? Okay, now thank you everyone for today's excellent sessions, and I would like to thank Dr. Sokan for sharing these very interesting cases, and Dr. Key for the valuable panel comments, and all the professors and colleagues for their active discussions. So the next International EGM Case Conference will be on July 4th, and with Malaysia as the presenting country and Mongolia as the panelist country. And thank you again, and see you next time. Thank you.
Thank you.
Have a great
Thank
day.
you. Good work. Good
Thank
case.
you.
Thank you, everyone. Goodbye.
Bye-bye.